This is the Exam Room Podcast. If value-based care is supposed to represent better care, why isn't it being applied to every patient? In part 2 of this conversation, Dr. Ben Schwartz challenges a fundamental assumption that payment models alone can drive better outcomes. Instead, he argues that value is created through care design, not incentives, and that many organizations are struggling to translate strategy into everyday practice. From physician buy-in to financial sustainability, this episode explores what's really standing in the way and what it will take to move forward.
So the question I keep coming back to is, if value care represents better care, then why aren't we practicing this way for every patient?
I think, again, it comes back to how you define value. I think some people, and I've argued this before too, are that, value is intrinsic. It's not defined by the payment model. So whether you're in sort of a value-based care payment model or non-value-based care payment model doesn't necessarily mean you're delivering valuable care or not. And I think that's, I would argue, why I had success in BPCI-A is that I was already delivering, valuable care before I went into the program. The program didn't make me more valuable; it just sort of uncovered that value. And I think that's true of anything. If we think that a payment model is going to deliver value or create value for people that aren't necessarily delivering high value care ahead of time, I think that's the wrong framing. I think if you go back and look at the original sort of Porter and Teesberg book about value-based care, they would say it's not sort of teaching to the test or the incentives, it's really redesigning care models to deliver a value, not setting up this value framework and then changing the model to meet the framework. So I think it's sort of a first principles thing where we have to change care models and then deliver value instead of coming up with this payment structure and thinking that that's going to force people to become higher quality or deliver more value.
So do you think most clinics get stuck there?
I think most clinics get stuck in that, they just know how to practice a certain way. This is the way that they've always practiced. I think if you don't know the data or you just kind of assume that, hey, I'm a physician, I'm a good physician, I'm doing things the way that I was trained, and this is high value care. I think maybe in your own mind, you feel like, hey, I'm delivering valuable care. The payment model is not going to tell me to deliver valuable care. The way I do things is the way that I do things. And I think, and if you don't know your data or you just sort of go based on what you think your reputation is or what patients are telling you, and sometimes you can be surprised. So I think it's just we haven't traditionally kind of looked at it that way. I think most practices look at it as, I've got patients to see, I've got patients to treat, I'm going to treat them the way I was trained and to the best of my ability. And I don't necessarily have a frame of reference for that. And, in the past, we really haven't had a mechanism to, bring that to the surface. I think value-based care does in a sense, and it can be a little bit of a mirror, which can be difficult to see. And I think people maybe who, again, know that they're going to be successful or pretty strongly believe they're going to be successful go into these voluntary programs, and people that are a little less confident, maybe stay away from the mirror.
So what would you say are the risks of running these parallel programs where we have a clinic, they have this very fee for service mindset, they have to do that to pay the bills and keep the lights on, and then now they have this value-based care model, they're looking at Medicare, Medicaid, for us beneficiaries that are under this model, but then they have all their other patients that aren't. What are the risks in that?
It's difficult, right? It's difficult. It's hard to treat one group of patients one way and a different group of patients a different way based on what their, payer is or what have you. It's hard to keep those parallel tracks and keep everything straight. I mean, we hired a nurse navigator when we went into BPCI to help us keep track of those patients. But that she was doing work, I mean, she was great, and she was doing work behind the scenes. It wasn't necessarily changing what I was doing for the patients when I was seeing them in the office or in the operating room. It's just very hard to do things differently for one group of patients than another and keep track of that. So I think you either have to adopt those protocols for everybody or consider whether or not you want to participate in these programs. But I think if you're going to start treating patients differently based on their payer, it gets very, very tricky.
Yeah, so what do you think it takes to adopt that model of care, I guess I would say, for every patient across the board?
I think the incentives have to be there. I think you have to feel like you're successful. I think you have to feel like the upside is worth it. And that's another, issue and reason that value-based care hasn't taken off either, particularly in the commercial market, is because oftentimes it's just the incentive isn't enough to leave fee for service and go to value-based care. You're just better off financially. Fee for service, for all of its ills, is easier to wrap your head around conceptually. It's easier from a billing standpoint to do a service that get paid for the service. Value-based care, if there's a reconciliation period or there's, dollars at risk and things like that, it's harder to, plan for the future of what if I have a bad reconciliation period or a bad quarter or whatever. It's a little bit harder to plan. Based on that, fee for service is easier conceptually from a kind of financial standpoint. And so I think we just have to design programs that are sustainable and the upside is worth it and the downside is manageable or tolerable.
Yeah, I know a pain point for our own FQHCs is that it's often a year to 18 months before they see any return on their investment. And they're putting all of this time and effort and resources into this upfront. They're needing to use their fee for service model to support what they're doing now so that they can see a return on their investment a year and a half later.
Right. And that's sort of the downside is that there's a lot of uncertainty and it's hard to run a business when you have that level of uncertainty. If we get to a reconciliation period, all of a sudden you had a bad, period and the money coming isn't what you thought it was going to be. How do you adjust for that? Margins are already tight, not just for FQHCs, but I think independent private practices as well. The margins are tight. It's a hard way to run a business if it's that unpredictable in terms of what your cash flows are going to be or penalties or what have you. My understanding with the LEAD program is that CMS is trying to account for that with some upfront payments and things like that, but it is a downside for sure of value-based care, which makes it harder to switch over from fee-for-service.
So many organizations talk about value-based care at the leadership level, but translating that strategy into daily practice, right, is where a lot of models struggle. In your experience, what does moving beyond leadership look like in a value-based organization?
I think leadership is finding the people that embrace these things, that have success in these models, that embrace the concepts of these models, and giving them input, giving them say, allowing them to help kind of design these programs. And that's at the CMS level, it's at the practice or hospital level. If you're going into these programs, get people involved that are actually on the front lines delivering the care and really are the ones that are determining whether or not you have success. And if you can criticize the team model that rolled out is that they sort of cut surgeons and physicians out of the equation directly. So the hospital's at risk for the work that the physicians are doing, but the physicians, unless you go into a gain sharing agreement, which the hospital's not obligated to do, the surgeons don't really, the doctors don't really have a dog in the fight. And I think that's a mistake. You want those people at the table. You want them, leading the charge, the efforts, because they're the ones that are ultimately going to be making the decisions at the point of care that determine your success.
And when I first started working for VB Care a few years back, and I started having conversations with like middle management and, those that were on the front lines, they were like, VB Care who? Right. So I think that's just case in point that there needs to be somebody at the table from every part of the day-to-day clinic workflow on up so that they really have buy-in and they have an understanding of what, leadership is trying to accomplish or even why they chose to, do this in the first place.
Yeah, for sure. And look, there are people that say, look, I just want to practice, I want to treat patients. I didn't sign up for, getting involved in these complicated programs and looking at these metrics and what have you. And that's okay. But if that's going to be the case, then you need a strong physician leader who is interested in that type of thing, that has a relationship with those other doctors to, make sure that they're participating in the program, but in a way that is acceptable to them, that they don't feel like they're, being told that they have to do X, Y, and Z to satisfy whoever's benefiting from the program, the hospital or whoever, but they're doing it because it's good for the patients, because it's evidence-based or what have you. So I think not everybody wants to be at the table. Not every doctor wants to be at the table for these models. Find the doctors that do, but they also have to be somebody that can kind of translate that back to the group as a whole.
Yeah, absolutely. I mean, is it silly to say, like, you know, these two providers are going to focus on value-based care and the rest of our providers are going to focus on fee for service? Like, do clinics do things like that?
It's tough to do that. I mean, I think a lot, and that's another, potential downside of these programs is that obviously there's a mix. I mean, you can have a hospital health system or practice where there's 10 different doctors and they're all going to kind of fall at a different level. Some of them might be high value, some of them might want to be low value, or some of them might be low value. And how do you kind of reconcile that? Are you referring just to the high value people? How do you cut the low value people out of the equation? Can you make the low value people high value people? But I think it's difficult, just like it's difficult to treat different, payer patients differently. It's difficult to treat different physicians differently, within that framework. But at the same time, there's this tendency to kind of drag down the high performers. If everybody's sort of getting dragged down to, the mean or to the lowest level, the lowest performer, you also want to avoid that. So that's another challenge. I think that's why you need good, strong physician leadership at the table and a good relationship between your, administration, whether it's your practice administration or hospital administration and the doctors.
Hmm. Absolutely. So I'm hearing sustainability, like, being, if we're going to employ these models, how do we make it sustainable clinically and financially? What are your thoughts?
I think it always boils down to incentives, right? I mean, we're human beings. We respond to incentives. We respond to, what's in it for me. And that can be financial. It doesn't always have to be financial. I think it's transparency. I think it's, workflow. I think doctors don't want things that are prescriptive, that they feel don't make sense. It's just somebody telling them to do something that for some purpose that doesn't really have anything to do with patient care. So maybe it's we're going to help make you more efficient in the clinic, in the OR. We're going to give you the tools. The money that we save in this program, if we all save it as a group, we're going to be able to invest more in staff and equipment or what have you. I mean, there's different ways to incentivize it, but at the end of the day, I think where the friction comes in is when physicians are asked to do something, but they don't feel like there's a clear benefit to them for doing it. So I'm doing the work, but I'm not seeing the benefit of that work. And that's when you start to get pushback or lack of buy-in.
Yeah, everybody wants to know the WIFM. What's in it for me? So if you were advising CMS today, what would you tell them?
I think I would say, again, make it simple, make it straightforward, make sure that people that are high performers are trying to do the right thing, are not victims of their own success. I would say, maybe consider that we've had however many years of value-based care, and we seem to just keep building on the same principles of maybe, try something different, try something that's a little bit more straightforward, not to be self-serving, but what we've had from the physician perspective is declining reimbursements in fee for service over, a period of many, many years. We get not only a cut every year, but it doesn't keep up with inflation. And so overall, you've seen inflation adjusted payment to physicians go down. Hospitals do get an adjustment every year for inflation. And is that contributing to the problem, right? If you're sort of in fee for service, you've really debilitated the fee for service system. Maybe start there and see if that doesn't fix a lot of the problems rather than try to design these complicated value-based care programs, move the needle an inch where maybe there's less consolidation if you have independent practices, or we stop sort of squeezing physicians in the fee for service model and we stop dumping administrative burden on them with MIPS and MACRA and all these, reporting requirements. Maybe instead of making things more and more complicated, what happens if we try to make things more straightforward and support physicians, particularly independent physicians? Could that solve part of the problem? I don't think we've answered that question. Yeah, I mean, I've done a lot of work with sort of value-based care, not on the CMS side of things, but more on the employer side of things. I think that's becoming more and more commonplace because obviously employers are getting hit hard with healthcare costs, particularly specialty care, particularly MSK specialty care. And so those relationships tend to be simpler. They tend to be more straightforward. They tend to be easier to administer of, here's, we're going to pay you X amount of dollars for that procedure. We're going to put some of that money at risk where it makes sense if there's some complication tied to that actual procedure. And that can be very successful to kind of simplify things. And it's not these complicated metrics. It's not hard to administer. So I think there is opportunity, and however you want to define value-based care, to incentivize cost controls without taking the position out of the equation or making it overly complicated.
This is totally off topic, but I was just thinking about, the years when I worked in surgery and I did a lot of orthopedics with one particular surgeon, and we were doing a bilateral total knee replacements. And I remember him mentioning something about how he only got reimbursed 50% for the second joint replacement. And that just never really made sense to me. That does not sound like they're incentivizing surgeons to.
Yeah, and the argument is that, you're already sort of in the OR, you've already kind of set things up. And so it's not like completely starting from scratch. But yes, at the end of the day, how do you put a number on that and say, well, it's 50% less work? I will say, having done simultaneous bilateral knee replacements, the post-operative work is twice as hard, even though it's one procedure. Twice as hard for the patient too in terms of recovery. So yeah, I mean, I think a lot of the mechanisms are maybe in theory make sense, but in practice don't make as much sense. I mean, I was reading an article recently that said that if you look at 2006 and in inflation adjusted dollars in 2026, you're now getting paid about $800 to do a hip or a knee replacement. And, my argument is always that we talk about value-based care. And I think what CMS learned in BPCI was that surgeons were already delivering value in fee for service. And they were probably, underpaying the value that they were receiving. And so again, I think how you define value is matters a lot, and who's defining value. Because if you ask patients, patients think that surgeons get paid like $10,000 to do a joint replacement, when in reality, CMS pays about $1,400 for a hip or knee replacement.
Yeah. Whoever makes those decisions, I would just like to bring them in and let them see how much work it takes to just replace one knee, and then it takes just as much work to replace the second one.
Yeah.
So as we're wrapping up here, I just have one final question for you. If we were having this conversation 5 years from now, what would you hope we'd say about the future of value-based care?
I think I would hope that we sort of hit on something that made sense, that was administratively straightforward, that made sure that high performers were not victims of their own success, that patients had access to high quality care without kind of feeling like they were being restricted or care was being rationed, or that their experience was any different or any worse. 5 years in healthcare terms is not a lot of time. But again, CMS said by 2030, they want everybody in some form of value-based care, and that's less than 5 years away now. So we'll see.
Any closing thoughts? Anything we didn't talk about? Anything you want to say as we wrap up?
Yeah, I think as much as there may be a backlash, or maybe people have soured on the idea of value-based care, I don't think it's going anywhere. And so I think you can sort of be turned off by it, or try to ignore it, or be jaded about it. But at the same time, I think if you want to see the table, or you want something different, then you have to kind of get involved and take an active role. And I just hope that other stakeholders will come to the table as well. CMS will come to the table, hospitals and health systems, that we can all kind of get on the same page and try to work together to make it successful.
Me too. Thank you so much for your time today. I really appreciate it.
My pleasure.
You've been listening to the Exam Room Podcast. Across this 2-part series, Dr. Ben Schwartz offers a candid perspective on the future of value-based care, highlighting both its potential and its limitations. As healthcare continues to evolve, one thing is clear: real change will require more than new payment models. It will require alignment across providers, systems, and incentives. Be sure to subscribe for more conversations on the future of healthcare.